Part of this collaboration has to include the liability. One of the things that you asked earlier on is the doctor held accountable? He is the main accountable person because he has the liability of the procedure.
Is that enough? I understand the argument that every physician is subject to civil suit if the patient is not happy. I understand that well, and I understand the fact that malpractice has driven many physicians, good physicians, out of their hospitals into other states, seeking relief. That being said, though, is that enough of a safeguard? That being said, if Karen's hospital is struggling, to what degree do they have a right to sit down with the doctors and say, "Doctor, this is what we can afford, period, or else we're going under"?
Well, I think we talked about collaboration. It is the answer. Things like supply chain efficiencies or operating room turnaround initiatives, sharing data with physicians so they can actually see the cost of the procedure, how they may be out of line in terms of their implant costs, asking the physician to work with them to talk to the supplier to try to reduce those costs in line. I mean, clearly that is the answer. It's not at this point that hospitals are going out of business. I mean, there are some that do every year. But I think generally speaking, hospitals are slightly profitable. What we're talking about here, though, is a trend that is going the wrong direction. And it's not just supply cost, it's bad debts. You talked about the automobile companies. I assure you there's not a single automobile company or any other company in any industry in the United States that has 10% plus bad debts in charity, where they're just writing that off. You know, every time the average patient comes in, the average revenue write-off is over 10%. So there's a lot of challenges beyond just medical device cost, and I do think we've got to learn to communicate with our doctors, collaborate with them on things that are important to them, that make their lives better, to make their business better. Hospitals are not going under, so to speak.
And if they do, I'm based in Philadelphia, and we have had one or two major hospitals in the last couple of years go under. There is a third that is really teetering on the brink. And while it's certainly hard on the community and it's difficult for the people who work there, in the overall scheme of things, is a hospital like any other business, if people don't patronize it and it goes out of business, that's the free enterprise system.
Well,
yes.
And I think part of what you're going to be seeing there is this recent CMS release of the moratorium from specialty hospitals. If the specialty hospitals, I mean, everybody that you read of lately, there's going to be this onslaught of specialty hospitals taking the more profitable procedures out of the community hospitals, therefore putting the community hospitals in more harm's way. I think there's going to be some kind of shakeout from that standpoint, and it's going to be addressed in the same manner as reimbursement.
I think with the new IPPS ruling, though, with the new reimbursement, they are squarely looking at the freestanding facilities. I think the reimbursement will not be as lucrative in the future as it has been for the freestanding facilities.
But you notice they said they don't anticipate that that's going to be a problem or a diminishing effect on them. They're going to continue to be a proliferation, even though it's going to be weighted in the future, severity weighted.
When we talk about healthcare, there's a tendency in this country, especially among healthcare professionals, to demonize pharmaceutical companies. Should they be?
No.
It's a free enterprise system.
I mean, they're making a product that people want.
Well, they need. Pharmaceutical companies have done great things for patient care over the years and continue to do that. Their research and new drugs they're terrific. So no, they're not terrible companies. They're great companies. I think it's the same type of arguments that we've talked about with medical devices. Are their profits too high? You can buy drugs outside the United States, same drug, much cheaper than you can in the United States. So why is the United States subsidizing the world's health care? I mean, there's a lot of issues there, but they're certainly not the bad guys. It's just part
I was
of the
reading
system.
coming down here today that the study was done by Harvard. Talking about $19,900 per year is what we paid for each year of extended life. And it's trying to, although there's a lot of pros and cons of whether it's a good study or not, I think, again, we're back to that effort even with pharmaceuticals, because they are attributing that to the drugs that have been developed over the last 40 years that has extended the life. Mm-hmm. And it has actually been very cheap at that level. For $19,900 per person per per year of extended life, well worthwhile.
Okay. Let me, if I can, Doctor, I'll let you in just a second, but let me invite those of you who have been a terrific audience thus far to chime in. We have several different microphones placed throughout the room, and when different comments have been made, I've heard murmurings from certain parts of the room, so here's an opportunity to actually get up and if not ask a question, certainly express your own opinion, and we'll go to those microphones when there's an individual who's ready, willing, and able to make. We got somebody out there already. Highly opinionated crowd. That's what we like. Let's go out there. Yes, sir.
How are you? John Morkovich from St. Anthony's in Missouri. I've been in healthcare for 30 years, and one of my biggest concerns, I agree with about reimbursement, it's really upside down. It's crazy. When you talk about the finance of hospitals to other people, they shake their head and say, how can you continue with that? But here's a question that's sort of outside. What is the AMA going to do as a lobbying body to go after the insurance companies that constantly deny care?
Is that the AMA's job?
I don't know whose job it is. I just spoke to a patient of mine the other day who had a total joint, and he told me, Doc, I just got a bill for $2,000 for my physical therapy. And I said, how is that possible? You have an insurance, and you have an HMO. Why are you getting this $2,000 bill? You know what he told me? Well, every time I go do a visit, I have to pay $60. So I went to my office manager and said, what is a charge to the therapy, to the patient every time they go to therapy? Guess what the charge is? Around $60. So they're selling insurance to this fella. He's paying $500-600 a month, but yet, you know what the copay for that insurance was? $60, which is what the payment for the entire visit was. So basically, he has insurance, has a catastrophic insurance, but everyday usage for office visits, by the time they do all these deductibles, they're basically paying all their own health care.
Do you think, Karen, that it would do any good for, be it the AMA or be it anybody, to go after the healthcare companies? I mean, they're in a business too.
They are in a business, and I think what's interesting is that for the first time in many markets, the payers aren't making much money and the providers aren't making much money. So in some markets, Boston being one of them, it's actually it's a very difficult situation between both of them. There's not much money to flow either way. But you started to talk about the individual. I think there is some individual responsibility in this as well. I mean, we've gotten to the point, insurance is literally insurance. It's supposed to be for catastrophic, and we've gotten to the point that in America, we basically think we have free health care once we've paid for our insurance. And so I think that there's some element of responsibility that also falls on the consumer.
I think that there should be some coverage. If you're paying for insurance, I think they should provide some coverage. In other words, he shouldn't be responsible for basically the entire coverage. As far as he knew, that pay must be, because they do usual and customary charges, so that they'll see a bill for $150. In actuality, the contract bill is only $60. And so behind the scene, he's actually paying for the entire bill because the contract was only for $60, even though the usual and customary was $150. So that patient basically bought an insurance for purely catastrophic, and had he known that, he might have gone out and bought a true catastrophic insurance for a much cheaper price.
Okay, let me go back to the audience. Yes, sir.
Thank you. My name is Mel Meck from Atlantic Care. I know there's been a lot of talk about the cost of the implant, but there's also a lot of cost opportunity savings in the whole clinical pathway. And I was wondering if there's any opinion on the whole notion of gain sharing to contain costs and reduce them. Thank you.
Well, I'll take that. Number one, if you look at the cost of what we've been talking about